Thank you very much, Kriti, for this very nice introduction. Sounds like a busy man. It was spread over several years, these activities. I thank the British Society for Surgery of the Hand, especially Carlos, for this prestigious invitation to talk about our experience of PIP joint replacement. I tried to cover different aspects, and I will be happy at the end of the talk to answer your question or get in some discussion rounds. So when you're talking about finger joint replacement, I think we have to distinguish the typical anatomical areas like the MP joint, which I always call the good one, the PIP the bad, and the DIP just the ugly one. Why is the PIP joint the bad one? It's very often in osteoarthritis, which is not always the case for the DIP, for example, very painful for the patients. Since it remains quite often some mobility, this pain is functional relevant for the patient. It's a very important joint, as you all know, for in osteoarthritic patients. So it's number 2 if we are counting all different localizations, beginning with the DIP joint, go to the CMC1 joint, and the PIP joint are the 3 major ones which are affected by this disease. Of course, it's the main motor for gripping. And it's also a very important motor for fine-tuning and all these coordinations activities. When we are dealing with the PIP joint, we are always some deals between mobility and the stability. This is extremely important, especially for the radial rays, including the index and the middle finger, which are working together with the thumb. And as we know, we need there some lateral stability. What are the indications for PIP arthroplasty? I think over the years, and I'm now more than 25 years in the same institution, and as Carlos already said, I had some very honorable masters to learn of, but the indications definitely got wider over the years, and we see more and more patients which are affected by this disease. All fingers are good candidates for a PIP joint replacement, especially also the index finger. There's always a debate, even in the literature now, if the index finger is suitable for a PIP arthroplasty. I will come back to that subject a little bit later, but I think yes, it is, and we have several proofs for that. Of course, you need functional tendons, reasonable ligaments. If ever a correctable deviation of the finger, the osteoarthritis often leads to a deviation problematic. And if you are treating patients suffering from a rheumatoid arthritis disease, it definitely needs stable inflammatory condition to consider a PIP arthroplasty in both patients. Be careful, especially if you're not that experienced, to deal with swan neck deformity for PIP arthroplasty, even more boutonniere deformity. Why boutonniere? The boutonniere makes a flexed PIP joint, and functionally, although it looks ugly, the boutonniere deformity is often very well compensated. This is in contrast to the swan neck deformity. Be also careful with surgical multiple violated PIP joints, especially in post-traumatic condition. They tend to get A, stiff, and B, painful even after a successful and well-done arthroplasty. We're always asking ourselves, when it is a good time to operate a patient? We all see patients on a daily basis suffering from PIP, osteoarthritis, and we are asking ourselves, should we offer them conservative therapy? Should we wait? What should we consider the patient when to show up for surgery? We're trying with our research department to get closer to that question with different studies. A very recent study, which has been already submitted to the journal, is a study where we try to find out when is the good moment to give the patient the sign that he should show up for a PIP arthroplasty. We used the so-called PASS and the so-called MIC. So PASS is the patient acceptable symptom state. So how much symptoms does the patient still tolerate? The MIC is the minimal important change. So how much change do you need before and after the treatment that the patient judges his procedure or his treatment as successful? And we try to identify that in these patients with 263 implants in 214 owned patients. They were all analyzed in that manner. What did we find? Interestingly enough, the best results were achieved in patients which had a pain level at rest between 2.5 and 6.5, which seems to be rather large. But interesting enough, if you're asking about pain in activities, it's around 6.5. This patient group has by far the best indication, the best results post-operative. In terms of the Michigan Hand Questionnaire, the brief version around 42 points, and the range of motion between 45 and 60, 65 degrees were the best. So the conclusion here is clearly, don't operate too early nor too late, which means if you have a completely stiff joint, it's probably not a good indication for going for a PIP arthroplasty, nor it is a good indication if you have a patient which is still moving 90 degrees in flexion extension. How about the choice of implant? Some of you might already have seen that. I always call it, that's the crossroad, that's the map of indication of PIP arthroplasty. Don't be afraid, it's not as complicated as it might look like, but we tried, that's what we have in mind when we are talking to the patients, when we are planning an operation, and I think it has to distinguish between different levels. Number one, again, you need functional tendons. Number two, you have to judge about the bone stock. Number three, how much deviation, how much instability do you have in those joints? Is it correctable or not correctable? And then lowest level in that regard is which finger is affected. And this all may influence the indications for the different implants which are available on the market. So for example, if you have the classical osteoarthritis patient with a good joint, which means intact tendons, hasn't had surgery before, a good bone stock, a little joint axis deviation. If it includes the radial fingers, so index and middle finger, probably a surface replacement is the best choice. If you go for an ulnar finger, so a ring and small finger, you might also consider a surface replacement, but we observed that a silicone spacer in most of these cases does do a good job as well. It's a bit different if you have more joint axis deviation. So if you have more instability and thus also less competent lateral ligaments, which helps you to guide your joint. We are really persuaded, and we can prove that with own figures as well, that the surface replacement in those cases is by far the better long-term investments, especially concerning the axis of movement and also the long-term stability. Be careful with patients which have a significant deviation, a significant instability. We quoted here 30 degrees and above. I think there probably a joint fusion is the best indication. You might, in selected cases, consider a two-component semi-constrained implant in those cases as well. How about deficient tendons? How about joints which are really completely destructed? I think at the end of the day, joint fusion is here the better option. For joint fusion, just a few points. And of course, there are different fixation techniques. You see a little bit an exotic one here with a single screw, which is technically not that easy to perform, but if you take a cannulated screw, you can nicely prepare that with the K-wire and screw it in. You have to be careful about the fusion angle, which is really critical in those patients, and a maximum of 40 degrees of flexion has been shown in most patients as the top level which you should perform. The more extended you do it, the nicer it is, so you have to consider that. Be also aware of the fact that the more ulnar you go, the more flexion you need. The less ulnar you go, probably more extension, again, looks nicer. What implant, again, should you use? I think the Silastic implant still serves nowadays as a spacer, as a standard implant. I think it has been proven in several studies, including our own publications, good long-lasting results with quite a low failure rate. And I mean failure rate in terms of clinical result and not implant itself. We could have shown that in the personal experience, less than 5% of patients needed revision after 10 years of the implantation of a silicone implant. It is the encapsulation, the scar reaction around the implant, which helps us there and which provides us these long-term results. So at the end of the day, even without the implant, even if the implant is broken, we have such an encapsulation around these silicone spacers that there is enough stability to provide a reasonable function. But nevertheless, and this is clear, it's also, we see that daily, the control of lateral deviation is almost impossible, at least in the long term. And the correction as well, it always goes the same. If you have a significant deviation of the PIP joint, you put a silicone implant inside, it looks nice for several months, and then already very quickly it starts to deviate again. And at the end of the day, after 6-9 months, it looks the same in terms of deviation as before. It's just the pain has gone away, and maybe the mobility is a bit better, or at least you could preserve what you had beforehand. Again, there's good pain relief, and the average range of motion, in personal experience as well as in the studies, show around 50 degrees of range of motion for flexion extension. There are several types of silicone implants on the market, although the numbers and the variations are vanishing due to the new medical device regulation. A lot of companies decided to retrieve their implants from the market because they have to do a recertification, which costs a lot of money, and in hand surgery is not that money for the industry as in other fields. That's the reason why some of these implants are disappearing. They look like a hinge spacer with several forms. I just quickly mention a few points about these different forms. So we have the original, the Swanson implant, which has been introduced in 1968 by Alfred Swanson, which I had the chance to meet and was a very impressive personality and a real pioneer of hand surgery. They have a really good long-term record. Due to its simple form, it fits in almost all joints. It has also a sizing which allows very small PIP joints of the small fingers to be fitted. It is flat, and theoretically, at least, through that form, it has a poor tendon moment arm. We would expect, at least, again, theoretically, that there might be a problem in extension. It has never been proved, to be honest. Then we have more like the hinge type of implants. The newest generation is the Keriflex, which is basically some modification of the new flex. I was involved in that redesign of these Keriflex implants. It's a block design, and it at least, again, theoretically improves the tendon mechanics. With its elliptic shape, which wasn't the case in the new flex, it fits definitely better to the cross-section of the joint, of the PIP joint, and it has better rotational stability, and this has been shown in several occasions compared to the Swanson implant through its rectangular stems. Nevertheless, the results are very similar in both implants. What are the alternatives to silicone? There are some two-component implants around. Some, again, disappeared from the market. One example is the pyrocarbon, which is still available, and I think it's in the UK still pretty popular. The problem of the pyrocarbon is it has no modularity. There are single-piece implants, and we all know through several publications that it's difficult to get an osseointegration with this material. In our own series, with a 10-year follow-up of 15 implants, which we compared, by the way, after 2 years and after 10 years, we have seen that the pain relief was still very good and quite impressive, even after 10 years. The range of motion started with 36 degrees of preoperative rate of motion. After 2 years, we got some slight improvement, and the same cohort, again, lost range of motion after 10 years. We had a lot of visible implant migration, which really look ugly. So after 2 years, we had about 8 of these 15, and after 10 years, interestingly enough, it remains quite stable. We had 60%, and some of them, again, producing X-rays like that, which is not very favorable. But to be fair and honest, not all of these patients needed revision surgery. What else is around? The Tactis from Stryker, just been sold now to DJO, a American company, recently, a few weeks ago. It's a very, and probably is the highest modularity implant on the market. It's non-cemented, but has quite big endomedullary stems, which might produce sometimes a bit of problem because it can crack the bone if you are rasping a bit aggressively. But it's an interesting implant, especially through its modularity. Another implant which some of you might be familiar with is the Matt Ortho PIP replacement from Ian Trail and his group. I personally have no experience with that implant. I don't even know if it's available in Switzerland, but it looks pretty similar like these two-component implants. I think of the very interesting feature here is the little rotational platform, which reminds me on the knee joint, which provides that, the meniscal bearing and rotational platforms they offer, which should compensate, number one, for the physiological rotation every finger has, and for the different shapes of the different PIP joints. There is one good publication with 100 implants of the Matt Ortho PIP joint with a follow-up, an average of 4 years. It showed a revision rate of 13%. Interestingly, no loosening at follow-up, but the survival of 85% at 2 years, and an average range of motion around 55 to 60 degrees. One implant, which I'm one of the authors of, is the CapFlex. We call it a real resurfacing. The two-component implant, they still have an endomedullary stem. We try to avoid that in order to have the endomedullary canal still open for revision surgery. And we were designing this surface replacement implant, which has a bit a different fixation principle. It has short anti-rotational stems with back coating, and it clips on the bone. And again here, it very looks like a knee joint. The PIP joint and the knee joint have a lot in common, also in terms of joint replacement. It offers different polyethylene heights in order to adjust tension. And I think from all the implants available on the market, it has the minimal volar resection and offering probably the easiest revision possibilities. If it really works, it might work very well and looks very natural in terms of range of motion. I'm sure a two-component implant which fits well can produce this as well, but it looks very natural how it moves, but it needs some pre-requirements in order to get such results. What is the advantage overall of two-component implants compared to silicone? I think the definitely main advantage is the lateral stability. And this, again, is important for the index and the middle finger in order to pinch with the thumb, but it also allows correction of a pre-existing deviation. And these implants also need, most of them, less bone resection than the silicone implants. So the revision with a silicone is almost always possible with these two-component implants. Just to show you about the lateral stability and its clinical features, we did a study on patients and also compared it with healthy joints. You see here 3 curves. The blue one is the curve of the lateral deviation of the PIP joint if it's ulnarly or radially loaded in a standard way. And you see there's a deviation up to 6 degrees in both directions in terms of lateral stability, ulnar and radial wise. If you see a surface replacement, in this case the CapFlex, that's the green line, it resembles very much the violet line, which is a healthy joint, and the healthy joint has about 1 to 1.5 degrees of lateral deflection, which is again very much also achievable with a surface replacement. I think thanks to the compression we have while flex and extend the PIP joint, we have the effect of having such a good lateral stability. How about complications? Of course they are, and they are not rare in PIP arthroplasty. That's why in certain cultures and in a lot of publications, they are quoted as a difficult intervention, as an intervention which might cause headache, which is basically not untrue. So we tried to analyze our own complication in 700 implants, which we have in our registry. And we could find a complication rate in silicone of about 11% and 20% of surface replacement, which reflects a bit what has been published in the literature, probably a bit less than the average. Re-intervention, on the other side, has been necessary only for 0.5% in the silicone patients and for 5% in the surface replacement group. Joint axe deviation, on the other hand, again, a proof what I just have talking about. In the silicones, we have in almost 60% of the cases, more than 5 degrees of lateral deviation. In surface replacement group, it's around 20%. Interestingly enough, although you think biomechanically it's a more sound implant, the surface replacement, the range of motion in both are the same. So I always say the range of motion is not a matter of the implant, but it's a matter of the scarring post-operative around the implant, which is extremely important. Looking at the different complications, no implant related, pretty similar in both groups. Stiffness have been observed a bit more in the surface replacement group, probably also due to the fact that it needs a bit more exposure. It has a longer surgery time. Maybe these are explanations for that. Soft tissue events, these are different things summarized, very similar. And Swannick deformity, interestingly enough, we observe in a quite high amount in the surface replacement. And I think this is the proof that the placement of the implant is an important part of the post-operative result in terms of recreation, the biomechanics which is needed. And the silicone implants, due to its flexibility, due to its material, is much more forgiving in that regard. In terms of revision arthroplasty, I think joint fusion is most patients the option. In order to compensate for the defect, you need some sort of bone graft in most of these patients. A silicone spacer might be an option as well, or a two-component implant, as in this example, where a patient already had 3 times changed its silicone, and she refused a fusion. So we tried, instead of a silicone, to put in a Tactis prosthesis, and so far it worked pretty well. There is limited range of motion, but there is still a motion of around 45 degrees, and she has a significant better lateral stability than she ever had with the silicone implants. What can you expect when you are revising a silicone? That's another study we published. We were looking at revision arthroplasty, so we replaced silicone with silicone in 34 joints with a follow-up of more than 3 years. And these are the results. You know, what can you expect? I think if the indication was mainly pain for revision, we had quite good to at least moderate results. So pain for revision is a good reason. We couldn't change mobility, so those patients who had a stiff silicone in primary surgery also had a stiff finger after the revision. Again, what we have said already 3-4 times, lateral deviation, especially ulnar angulation, which is present in most patients, it always returns. So if the indication is the deviation, you rather go for a fusion. And again, you know, implant fracture, although sometimes hard to detect on the X-ray, is not an indication for a revision per se. Let's talk about different surgical approaches. I think this surgical technique matters. Again, I said the result is highly defined by the scarring, so the surgical technique is important. From the dorsal side, we have mainly the central splitting approach or the Chamay approach, which are probably the two most popular. Let's look a quick closer to them. What are the advantages and disadvantages? The Chamay approach is technically rather easy. It provides a good overview. It's very reproducible, safe in terms of you don't violate the tendon that it rips away, something like that. And it has a long line of tendon suture. On the other hand, we observed quite a lot of disadvantages. It has a long surface, which provides a lot of surface for adhesions. So I will show you that in a minute, that the range of motion in the Chamay approach was less than in the central splitting approach. We observed, and this was interesting and goes along with that, calcifications on the undersurface of the tendons in quite a lot of patients. In some of them, they were active, so meaning they produced the stiff joints. In some of them, it was just a X-ray phenomenon. Volar osteophytes are hard to control by the Chamay approach because you have a problem if you're flipping the tendon, you don't reach, and the dorsal, also the dorsal osteophyte is difficult to control because you have part of the insertion of the tendon is going directly to the osteophytes. And again, this was the group in our series which produced by far the most swan neck deformities in all approaches. The central SIP, again, is easy as well. It has a very good overview, just there to expose the joint. I think that's important. That's what I learned over time. At the beginning, I was very cautious, but you will see I show a few pictures of it. We are very generous in terms of releasing and then thus having a good overview. Of course, the disadvantage is you have some detachment of the extended tendon. To be honest, they nicely heal in almost all cases, interestingly enough. But also in those cases, we had swan neck deformities, but by far less than in the Chamay approach. The volar approach, a bit less popular, but interesting, I think, in several circumstances, especially if you have a pre-existing swan neck deformity, you have very supple joints, which you fear that you have hyperextension deformity. In the long term, volar approach might be an interesting solution. We have a special way of approaching that. We try to form a sleeve of the tendon sheet, which can be rolled distally and expose the joint away that you have a nice overview. You can hyperextend the joint by releasing at least the accessories, but also parts of the main collateral ligaments in order to get a good exposure. The good thing, once the implant is in, you just stitch the whole sleeve, which includes the volar plate, with a few stitches there, and you can start immediate range of motion. You don't violate any tendons. The swan neck risk is absolutely minimized because you have a scarring on the volar side, which also produce less extension at the end of the day. But again, this can be an advantage for certain patients. I think it's technically not that easy to perform. You have to think a little bit upside down in terms of the view. The view is also limited, at least if you are a beginner with that approach, because you fear to do a generous release. I just want to tell you that you have to release a lot of this soft tissue in order to get a good view, and it doesn't matter because there will be scarring anyhow. And we observe by far more stiff joints postoperative than we observe loose joints. So you have to be careful with the noble structures, nerve and the artery. It's a matter of instruments. And again, you have the volar scarring, which can be your enemy, but also your friend. I personally don't have experience with the lateral approach. I've seen it performed by Ian Trail, very interesting, I think. It has been a nice publication by Greg Bain with a so-called modified lateral approach, which only releases the accessory collateral ligaments you can see here on the top, instead of having a complete release of the collateral ligament. Don't go to the radial side. You must release it from the ulnar side, because the radial side is the important one, which you are pinching again. Again, here you don't have tendon violation, I have to say, and this is one of the disadvantages. I tried it several times in the lab, and I had the impression that you do quite a lot of release of the dorsal surface of the joint, which again might be also a scarring factor. But I think it's an interesting approach, which also merits his existence. What did we find when we were comparing with one implants and just a handful of surgeons, the different approaches? We found in our own series again, the best range of motion with the dorsal tendon split. The best flexion was with the volar approach, and the least extension deficit we had with the dorsal tendon split, because again, the volar approach tends to scar on the volar side, obviously, and this might be a limitation for extension. The limit of this study is that we started with the Chamay dorsal approach, so there might be a learning curve inside, but since it was distributed among different surgeons, this has been compensated over time. What are we doing at the moment? In the index finger, whenever possible, we go for a surface replacement or a two-component implant, again for lateral stability. So this is almost a mantra. We are careful in indication for surface replacement, of course, in bone defect situations. If you go for a two-component implant, always have a silicone in the room in order to have a backup. Also, careful indication in rheumatoid patients, they need to be really stable in their disease condition. We go for the dorsal tendon split, meanwhile, as the standard approach. And again, there's some indications for volar approaching, especially in patients with beginning Swannick deformity, with a lot of instability to the dorsal side. We used in several situations in bigger bone defects, the Tactis implants, or even for failed silicone, a Tactis might be an interesting solution. So this is another type of schematic representation for the selection of implant. It's a bit easier. So bone stock, which finger is it, what the joint axis deviation, this might help you. Just a few technical points. Setup and approach. I quite often do now a PIP arthroplasty in local anesthesia. It has a lot of nice features beside of taking the fear away from patient from anesthesia. So you do a finger tourniquet, you go straight incision line. I don't like these curved incisions. I don't see the reason for. I try to keep the layers as good together as possible. So going down to the tendon, open that, subtissue, subcutaneous tissue all together, including the veins inside whenever possible, and then do a straight incision down to bone and detach the tendon completely from the bone. This needs a bit experience, number one, and you don't have to fear that you do an instability. Again, it will heal nicely. Then you already have the joint. You have to do some release of the collateral ligaments. And then you start with the resection here with a silicone implant at the proximal joint. You size it with a trail implant. This is a Keriflex. I always mark it with a marker, then do the resection freehand, try to be perpendicular on the bone axis. The good news is with the silicone implant, it's quite forgiving in this regard. Distally, I only do resection of the osteophytes if needed. I like to have a hard surface on the distal part, because the hard surface of the bone, I think personally, provides a better interface to the silicone and probably provokes less of silicone failure. I don't know, I couldn't prove it. Be careful with the dorsal central osteophyte. It's the insertion of the central slip. So you can trim it a bit away, but you shouldn't erase everything there. That's how it looks. So this is the resection, and then you have a awl to open it. Let you guide, you feel it when it slides inside. Then you have a starter rasp, which opens you the endomedullary canal, and depending on the implant, you have a final rasp for sizing. It's important that the implant fits loose to the endomedullary canal, because there is some pistoning, there is some relative movement of the implant endomedullary, which provides the longevity of the implant. Distal, it might be very hard. So in selected cases, sometimes you even take a burr, but usually with the pointed awl, it goes well. Starter rasp, and again, final rasp with sizing. Then trial implant, it's important to have a supple extension, not overextend, but it should be easily reducible to extension. Then insertion of the definitive implant. I always call it the semi-non-touch technique. I don't know, all of us, which are a bit of older generation, have been taught that Al Swanson always said, don't touch the implant because of negative charging of the surface and blah, blah, blah. I never understand it, to be honest. So I dare to touch it. And then you have to do the movement and the stability, and try the stability, which enhances as soon as you close the soft tissue envelope. And then I don't do any transosseous suture, nor in the surface replacements, nor in the silicone, because it scars down easily and it finds its insertion point when the patient is starting immediate range of motion. Do resorbable or non-resorbable suture as you like it. And the nice thing, if you do it in local anesthesia, you can ask and show the patient on the OR table how good he moves. So this is a very good learning for the patient and gives him motivation for the rehabilitation. In terms of rehabilitation, individualize it. That's the most important part. I always say there are losers and there are stiffness. Losers means those patients which will never get stable. And the stiffness, we all know much better, are those who are already stiff after 2 weeks. So I think we really have to work together closely with the therapists in order to identify those patients and react early. So if you have patients with lateral deviation, you can produce such nice hinge splints which allow mobility but still give lateral stability, or even dynamic splints if it's supported by the patients already quite early, in order to have some help to get a better range of motion. So to sum it up, the PIP joint, although it's the bad one among the different finger joints, I think it deserves to be treated. The results are somewhat predictable. It's not like the hip or the knee, but at least it provides the patients a often functional mobility with definitely less or even no pain. So I think, although it's the bad, you can make it better. Thank you very much.